histology will be a fourth of the test, and hematology will be a fourth of the test, with about 6 doses calc or so.
Wait, repeat that.
Half your test will be renal, a fourth of your test will be hematology, a fourth of your test will be oncology. Because next week we split 2 topics in a day. There's 2 different handouts, and we're just picking the hematology handouts up. If you don't want to take any today, I'll have some next week as well. I didn't even know. As we already talked about, the best measurement of fluid retention is daily weights for your patient as an outpatient. Helping your patient keep track of that, suggesting writing down on a tablet or some kind of thing like that. The first condition we'll talk about is chronic renal disease. The criteria, the umbrella term, is when you've had kidney issues for at least 3 months. That makes it fall into a chronic category versus an acute. Lots of things can cause a patient to have chronic renal failure. As you can see, the biggest ones are STARD, being high blood pressure, and diabetes that's not being managed well. So we have patients that are going around not managing their diabetes and thinking, well, I'm cruising okay. I had a neighbor lady that just would not pay attention to what she ate, and she would change her insulin amount every day. So she'd be like, well, today it was 400 and something on my glucose, but I just took more insulin, and I can go out tonight and just have a burger and fries. And I'm like, well, over time, I didn't say that, but over time, she's really doing a lot of damage to her renal system every day, over a period of time. So the 2 biggest risk factors are high blood pressure and diabetes. You don't need to know these stages by GFRs. You don't need to memorize this chart. What you do need to know is normal GFR is at least around 90 to 100. The lower the number, the worse things are. That's your ability to filter, your ability for your strainer to work correctly. So if you see this number on your patient and it's less than normal, they have some kind of kidney issue going on. Lower the number, worse things are. But you will not have to differentiate between which stage is which as a student, because it's just not necessary. As we already talked about, what direction labs, assessment findings will go. We already talked about that right before the break. First condition is nephrosclerosis. SCLERO means what? Hardening. Thank you. So that tells you what's going on with this patient. What size will their kidneys be? Big or little? If you have not had oxygenation to your kidneys, which size will your kidneys be? Shriveled up a little. Yep. Due to hypoxia over a period of time, because your vessels are hardened, kind of like your atherosclerosis patient. Same concern, your vessels are hardened, they're not getting enough oxygen, not enough blood flow through to those kidneys, and those kidneys will be shriveled up a little as a result. Again, your risk factors, as we already talked about in the previous slide. For this patient, we may see protein in his urine. That is not a normal finding. That is not a normal finding. You should not have protein in your urine. Because he has high blood pressure, oftentimes that whole Renal mess-up system, ACE inhibitors are often prescribed for lots of these patients. Know their names. ACE means angiotensin converting enzyme inhibiting. So that process is what keeps your blood pressure regulated. It's on overdrive for this patient. So therefore, you want to inhibit that process from continuing to increase the blood pressure. Know the names of them. They end in prills. Your patient comes in with renal problems. You see a serum creatinine level of 2. His blood pressure is 160/94. You expect what medication to be prescribed? There you go. Blood in the urine sometimes. Renal patients oftentimes will retain fluid. That just makes sense, right? Because your fluid is supposed to, you've dumped your fluid into your strainer. Your strainer is supposed to let all that fluid go through. You made noodles for Thanksgiving, and you dumped them in there. Your strainer is supposed to let all that fluid get all the way through. This person's renal system is not working correctly. It's going to retain fluid because all those holes in his strainer are not filtering through correctly. So fluid retention, oftentimes with all of these patients, no matter what kind of renal system problems they have. I don't know if you're making noodles or not, but I'm just trying to get that strainer there. So when you're making noodles for Thanksgiving, you can think about this lecture and you're like, okay. Anyways, high sodium levels are often a concern. Sometimes people memorize symptoms that go with high sodium levels by fried salt. That doesn't make sense to me, but you can pick it if you want. Sodium's a number you want to watch out for all your patients, because a little bit of fluctuation one way or the other causes lots of issues with your patient. So your patient comes in, you don't even know if they got what they've got going on, but let's just run a good electrolyte panel that's done some renal function tests to see for sure what you might have going on. Questions about nephrosclerosis, decreased oxygenation, hardened vessels, shriveled up little kidneys. The same lab findings, same assessment, same issues as we've been talking about consistently with other conditions. Nephritic syndrome, idic is inflammation. Idic is inflammation, acute, so that could be any of us, right? We're not talking about chronic, we're talking about acute situation. Oftentimes we find that occurs following an infection of some sort, and commonly a strep infection of some sort. The kidneys, the glomerulus are inflamed. Do a good history on your patient. Have you had a recent infection? The same assessment findings as we've been talking about. Maybe added to this one is the cola-colored urine. The rest of these are what we've been talking about all along. I would not continue to fill your notes with these with every condition, because these assessment findings go with all of these renal problems. That might be a good thing for your cover sheet from today. These are lab changes that goes with all these renal problems that we are going to be talking about today. And maybe adding to this for your note, the cola-colored urine, because that's a little bit unique to some of these that don't really go with the rest of them. High BUN, the wastes aren't getting filtered through correctly. We'll spend more time on that in a bit with some other disorder. Hypertension. When hypertension affects the brain, you start to see more significant neurological findings. We already talked about increased intracranial pressures 2 weeks ago. Of course, our goal is to decrease your blood pressure without messing your renal system up. And there's, like I said, there's lots of conditions that go with that depending on how severe it is. We will diagnose that inflammation by doing a biopsy. And then we'll kind of treat by condition, by presenting symptoms. I'm not going to spend time on, it depends on what number is what, as to whether they restrict your protein or not. Don't worry about that for today. There's a lot of dietary changes that occur depending on what the findings are, but I'm not going to have you spend time and your energy on that right now. Probably the biggest part to know about this one is that it's an inflammation, it's an itis, which is different than what, oh, I'm sorry. And that follows typically an infection of some sort, typically a strep infection. So your patient comes with acute nephritic syndrome. What should you look for in his history? Strep or infection, correct. Or what's an important question to ask him? Might be the way that would go. These could be asked at any point in time, all the symptoms. And when blood pressure gets high enough, we start to affect the brain and the whole neurological system. Chronic is as it says. It's an inflammation that's lasted a long time. Look there, 20 to 30 years. So it's an inflammation that's not an acute state. It's just been going on for a long time. Sometimes patients have no idea that kind of inflammation for a long time causes definite scarring and sclerosing, which just makes sense. How will the kidneys look if they've been scarred for 20 years? Will they be big or little? How are they when they didn't get enough oxygen throughout the years, or if they're inflamed and irritated for years and years and years? Will they be big or little? Little. Atrophy, decreased in function, because we've had inflammation that has been irritating those kidneys for 20 years. Almost always ends up with end-stage kidney disease, which just makes sense. They've been inflamed for years and years and years and years and years. Loss of function throughout. As it progresses, the same changes we've been talking about, adding to those lab findings, increased phosphorus. I would add that on to your list of labs, expected lab findings. When phosphorus goes up, calcium goes down. It's a teeter-totter. So high potassium, high phosphorus, high serum creatinine. Sometimes I'll see students for test D that will take their scratch paper kind of like you did with neuro, and sometimes they'll just spell out all that lab stuff right off the bat. You can do that if you want, if that's helpful for you to get rid of all that out of your brain before you start taking the test. It's entirely up to you. I do appreciate some of the cartoons that I see on the scratch papers and all that. Treatment again is avoiding meds that are going to be nephrotoxic, because that makes sense. Your kidneys are not working well anyways, much less throw a bunch of nephrotoxic meds on top of that. Altering the diet, considering if it's going to be chronic renal failure, what's going to be our solution for that? Nephrotic syndrome, that's different than nephritic. Itic is inflammation. Don't mix that up with this one. This one is when you've got a high level of protein in your urine. Your strainer has this hole too big, it's allowing protein to dump into the urine. A hallmark assessment finding with this one is the amount of protein that we find in the urine. It's nephrotic, it's an O, it's RO in the middle. That's how I know that goes with protein, SRO. Don't mix it up with itic. Itic is inflammation always. So protein in the urine, a lot of protein in the urine. A lot of fluid retention. Oftentimes, again, it's following some kind of immune response, and a lot of fluid retention that goes with this one. Questions about that one? Hallmark finding is what? Protein in the urine. So, and it probably won't be, your patient has nephrotic syndrome, what do you expect to find? The answer probably will not be proteinuria, right? It'll be, this is what's found in the urine. So look for the answer that says that number of protein. Polycystic kidney disease. It's an inherited condition where the kidneys have been replaced basically with a whole bunch of fluid-filled cysts. It's inherited, so you should have picked different parents if you didn't want to get this disease. The kidneys, unlike we've been talking about, will be huge, bulging, football, 20 to 30 pounds kidneys.
Oh my goodness.
Because their kidneys are bulging with cysts. You can palpate those kidneys as you can imagine. If you were going to palpate someone's kidneys and you got your hand back there and they have a 20-pound kidney as opposed to 4.5 ounce kidney, they're huge and painful, of course. Sometimes we can drain the cysts, but they usually fill up with fluid again. Easily palpable kidneys, well, that's kind of like a duh, right? Blood in the urine. High blood pressure. That is going to be your critical priority treatment, is for his high blood PKD. We can do diagnostics. The labs are consistent. Controlling the blood pressures in red and bold, and that's your priority. His blood pressure will be 210/130. It won't be like 138/92. That is your priority, to get his blood pressure managed, because otherwise he may have a stroke. And then considering some sort of dialysis or something else. So it's inherited, big bulging kidneys. You can palpate them, severely painful as you can imagine, and your priority, absolute priority, is to get blood pressure under control.
It's just gonna keep happening their entire life.
So it's not curable?
That's like,
Pardon me? Correct, not curable. Probably a kidney transplant. Like I said, we can drain the cysts, but typically they fill back up again. So like I said, you see has a different set of parents. Renal cancer. Oftentimes the risk factor is exposure to some sort of chemical. So do a good history. That chemical may include tobacco use. That's the biggest risk factor for renal cancer. Exposure to chemicals, including tobacco use. Oftentimes it doesn't produce symptoms. Sometimes we see blood in the urine. As things progress, the lab changes and all that kind of stuff. In red and bold, if you removed a renal cell tumor, the kidneys are very vascular. Pay attention to all the things that may indicate that patient's got bleeding going on following his procedure. By now, those should be pretty already sort of foundational in your brain. What's his hemoglobin? What's his blood pressure? Is he feeling dizzy? Are there indications that he may have internal bleeding of some sort? Hematomas are not normal, right? That's the blood underneath your skin that you notice, almost like a bruise. Mark the perimeter of that with a pen. See how big it's getting. Notify the surgeon or healthcare provider. I've noted a so many centimeter hematoma. Keep watching it, make sure it's not growing, make sure someone's aware that there's some bleeding underneath the skin. Why would their abdomen be distended? It's filling up with blood. Yeah. So, like other cancer treatments, which we'll talk about next week, there's lots of options for that. We have to remove the whole kidney, we may have to just do partials, all those things. Sometimes we have to improve the circulation to the renal arteries. So probably the biggest take home for this for you is this slide here. Your patient underwent a nephrectomy of some sort or some kind of procedure. What do you need to monitor for as their nurse? And risk factors. You're picking out the most important parts to know about it. Okay, acute kidney injury. It's acute. It could be any of us that has some kind of renal issues. So it used to be called acute renal failure. That terminology got changed because it was not really failure, right? It's just an injury that you had, and you had something that occurred to you that has impacted your kidneys. Again, your serum creatinine is going to be 50% more than baseline. There is a difference between oliguria and anuria. It's spelled out here. By definition, oliguria means less than 400 milliliters in 24 hours. Anuria, by definition, is less than 50 milliliters in a day. So 400, less than 400, as opposed to less than 50. That's the difference between those two medical terms. This one was included on your quiz assignment. This is a scale that gets used for us to determine where the patient is at. You do not need to differentiate between FNL and the E part of this. So, but given a patient, and I give you a patient that's 70, they have diabetes, their serum creatinine is 1. Where is she at on this scale? Risk. She has all those risk factors, yes, but her serum creatinine you told me was normal, so I'm not too concerned she's not here yet, but she is at risk given those conditions. Different patient, different day, and they have serum creatinine of 2.1. They've had 3 months of oliguria. Do not call them a risk any longer. Call them, you won't have to differentiate between I and FNL and E. The patient you had in your quiz assignment, she came in with a PE. If you remember right, she had decreased urine renal function. She came in with an acute problem, that PE, the pulmonary embolism. She was here. She's not chronic, and she doesn't have failure because she doesn't have months of that. She had an acute event that caused her to have decreased urine output. She had an injury. She was way beyond here because she had abnormal renal labs. And she's not here because she doesn't have a history of renal problems. Her acute decreased cardiac output on the front end, because she had a pulmonary embolism, caused her to have an acute kidney injury. She was here. And that's how she should have been rated for you on that Renal scale.
You said she was a failure because why?
Because she doesn't have a chronic or a long-term, it's an acute event. It was acute. She would have been categorized as an acute kidney injury. She hasn't had a history of persistent kidney problems. She's had acute kidney injuries where she was. So if you're going to get this scale in another couple weeks, that's how that would go. Similar to what you had on your quiz assignment, or the scenario I gave you where, yeah, her labs look normal, her BUN was 18, her serum creatinine is 1, I know all the normals for them, but you did tell me that she's older, that she has diabetes, something else. I'm going to put her here. I'm not going to put her here. You don't have to do all this, unless you want to.
So do we need to memorize like
No.
that chart?
No.
Just
Just know if I gave you the scenarios I just gave you, would they be categorized as risk, or injury, or failure? Failure is they had 4 months of urine output of less than 400 in 24 hours. No, that's why I don't want you to do all that math on that. You okay with that? You don't have to do all that math, because I'm not going to give you milliliters per kilogram per hour and all that kind of stuff, because that's kind of a crazy deal.
So, if it's injury, what's the risk of the lab?
Risk is, everything is normal except they present with risk factors. Because she's diabetic, because she has high blood pressure, but you looked at her labs and her BUN was normal, her serum creatinine was normal. She has risk factors, but she doesn't have any evidence of kidney issues. Rate her as an R in that scenario. Rate the one that came with PE that has an acute event that caused acute kidney issues. You don't see anything else that's been a chronic problem all along. She would have injury. The failure person would be a chronic, long history of 4 months of not much urine output, blah, 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 blah. It'll be clear enough which one's which. You guys good with that? Acute kidney injury. It's important to differentiate between what 3 things can cause you to have an acute kidney injury. Again, we're not talking about chronic problems. We're talking about someone coming with an acute problem that's caused their renal system to not get what it needs or not function correctly. So it could be a pre-renal problem, not enough blood flow on their front end, which is what your person that had PE had when they had that in your quiz assignment. They didn't have enough blood flow. The kidneys didn't get what it needed. It needs 25% of your cardiac output. Or it's an intrinsic problem. Their kidneys have been scarred because they've had diabetes that hasn't been managed well. They've smoked their entire life. They've had some kind of chemical exposure. They have structural damage. Not very fixable. Post-renal is everything's on cool on the front end. They don't really have structural issues, but they've got a kidney stone that's blocking the outflow. The pre-renal stuff is usually easiest to fix, right? You're dehydrated. you have low urine output because you're dehydrated. I get you some hydration going, give you some IV fluids, that improves. I fix this pre-renal problem. Your kidneys start working again, it gets what it needs, and we send you on your way, and those are usually more fixable than structural damage, of course. I think of that sort of as you're stuck in traffic. Is it a problem with too many vehicles trying to get on? Is it a problem with just a jerk that's in the middle of the traffic, or is it a problem with everybody trying to get off from the same exit to get off? So, whatever analogy works for your brain. Pre-renal, intrarenal, or intrinsic is another name for post-renal. So as we talked about, there's different examples of that. So you have a patient that comes in, they have some acute condition, but they are an acute kidney injury. The scenario I gave you in your quiz assignment was my sister that had a pulmonary embolism, so we were probably going to talk about her. She had a pulmonary embolism, so that was her acute event. She had really, really decreased cardiac output. That's what caused her to have acute kidney injury. So she had 3 days of anuria. So she had the onset phase was what caused her to have the decreased urine output, because she had very poor cardiac output for those days, right? And then she went into the oliguric phase, where she had really, really low urine output, because she didn't have enough fluid and blood flow going to her kidneys. And her labs will be consistent with what we've talked about. So the initial event, what caused the kidney problems to start, the low urine output event, labs are changing exactly like we've talked about, low urine output, either oliguria or anuria, high potassium, high BUN, high serum creatinine. The next phase is we now are trying to get the problem resolved. Things start to normalize, and the patient starts to urinate a lot. We finally got things moving, right? And then recovery is when things go back to normal. Hopefully they'll get back to normal, depending on how big the insult was, how long it lasted, a zillion factors for that. Yes, sometimes they can. They should normalize. So if you don't have urine output, you're going to have a high BUN, high serum creatinine, all that stuff, and all that stuff, when it starts to actually, the kidneys start to kick in, they all should get back to some normal state. They could, depending on how much they diuresis. You're exactly right. That's fine balance. That's a good question. We want you to urinate a lot, but we don't want you to urinate too much where we're sending it too far the other direction. Absolutely, good question. What?
So the onset, the initial phase, there's a feeling
Correct, because it's called acute. Correct.
So how will you know that there's something happening, like going on with it?
Well, like my sister that came with pulmonary embolism, we knew she had decreased cardiac output because she had pulmonary embolism. And she started, they put a catheter in and she had no urine output in her catheter bag for 3 days. Because her cardiac output was really, really poor. Her kidneys didn't get what it needed, so then kidneys didn't produce urine like it needed to. But once the PE got resolved, her kidneys just started kicking in. She got all those IV fluids, they resolved all that, resolved the blood flow, and then all the system kicked in, started having urine in her Foley bag, and went our way. Questions about that?
Do the labs change in the first or second phase?
It just depends on how effective. You know, it just depends on how quickly that initial problem gets resolved. If it's you coming in with dehydration, if we fix that with a couple of IV bags, you can move these phases pretty quickly.
Can I see the initial phase?
Sure. You know, the initial was the initial insult. So what acute condition caused the patient to have those renal problems? And then we noticed all those changes in the urine, the renal system starting to not function well, and all the resulting labs and changes that occur with that. Now we've got the problem resolved perhaps, we've got them hydrated, we've got the blood flow going, we've got the fluid levels going, and then your urine starts to increase, and hopefully your kidneys now start working correctly, and then hopefully that everything goes back to normal. It was an acute event.
So yesterday I had a patient, like, they say I had GFR at 9, and it was not like, he was not eating, so they put a cargo in him, and they were the same dialysis for implant. I don't know, I said it was implant, I don't know.
So they went through dialysis or they weren't going through dialysis yet?
He went,
Okay. They must have had that going on for a period of time.
so that would not be like initial situation.
Well, it could be, like my sister that had the pulmonary embolism, they started doing dialysis after about 2 days and no urine output. You know, because your kidneys gotta keep working at some point in time. So dialysis may be part of this scenario, depending on how severe things have gotten.
Do you do those labs when they're on dialysis?
Just constantly. You guys got great questions. So again, the decreased urine output, it goes with that. This is a definition between, you see that terminology, azotemia and uremia. Azotemia is when you see a high BUN, but you don't really see symptoms that go with that. By definition, uremia is you do have a high BUN, a lot of waste being held onto, and they are producing symptoms. So azotemia, increased BUN, no symptoms. Uremia, increased BUN with symptoms. They both indicate a lot of retention of waste regardless. You can do ultrasounds. In that scenario, expect the same kind of lab changes for your acute kidney injury patient. Same labs we've been talking about, that probably should be on your little cover sheet by now. Fluid overload, you know, your colander can't strain, they start retaining fluid, and then we're trying to diurese them, so we give them fluids, and they're retaining fluids because their renal system doesn't work right, and all the fine balance there, it gets to be pretty tricky for sure. We need to restore adequate blood flow, especially in that case of a pre-renal cause, as in the decreased cardiac output is what caused you to have kidney problems. Sure. So pre-renal causes is that you don't have sufficient fluid or blood flow that's arriving at your kidneys, so it can't do its job because of that problem. So this is a scenario you have today. You have my sister who has pulmonary embolism. Hers is pre-renal cause, right? She's got kidney problems because of that. She has decreased cardiac output. Her potassium will likely be what level? High. Because potassium is getting produced, right? And the kidneys can't filter it through and keep it normal. Yours filters yours through to keep your potassium at a nice normal level. Not the case for this. And we do know what happens with high potassium levels. Correct. So we've got to quickly act on that high potassium level. We've got to get that back down, get it within normal, because we don't want that patient going into some kind of detoxing bib, something like that. So definite treatment of that. If they got EKG changes that are present, obviously a really high level, we need to get that under control. We need to do it immediately. So that's your focus. Your goal is to stabilize those membranes so they don't get irritated and throw them into some kind of dysrhythmia. Here are approved treatments for high potassium. We'll go through them one by one. 1, IV injection of calcium gluconate. It stabilizes the membrane. Your patient's having dysrhythmias. You notice a potassium level of 5.8. You expect what medications to be prescribed. This could be one. This medication doesn't change the potassium level. What it does do is try to stabilize the cardiac membrane, so it doesn't go into some kind of dysrhythmia. Calcium is CALCIM, and CIUM. It stabilizes cardiac, so C and C together. It does not change potassium level. It stabilizes the cardiac pieces of that. This is sort of a weird fit, but we can give that patient insulin, and it tries to shift that potassium from extracellular to intracellular by design. Along with that insulin, we'll give that patient dextrose as the counterbalance. Because if we give you insulin, what's going to happen to your blood sugar? Down. So we're going to give you some dextrose. I don't know who thought of this magical formula, but it's pretty ingenious. They're probably sitting on a beach in Maui somewhere, not standing up here talking about renal. I tell my clinical group every week, I'm like, I'm going to invent something. I'm going to send you a postcard from the beach. Okay, that's the result. So we combine the insulin with the dextrose, and our hopes is to decrease that potassium level. It can decrease it by 1 milliequivalent within 15 minutes of time. So that's cool, that's good, that's what we're gonna need right now. Albuterol is sometimes part of this combination. Again, it stimulates the shift of potassium. And as you know, a complication, concern, side effect is tachycardia. You don't have to memorize how quickly it changes the potassium level, it's just a fun fact. Following those treatments, typically we'll give the patient a diuretic. We'll go through the diuretics after a bit. And I believe this was on your quiz assignment as well. Administration of this swaps out potassium for sodium. Sodium for potassium should be, I should have worded that. Kind of unpredictable though, it's not absolutely a first line medication because sometimes the result sometimes gets a little bit hard to figure out how that's all going to work out. And this is one of the latest, newest. Starts with a P, so does potassium, I don't know. It binds it up in the GI system, attaches that potassium to fecal matter, which increases the potassium excretion. Bless you.
So it's kind of like a diuretic, but they're moving off the potassium.
It's not a diuretic, it just binds to food.
But it's like not
Yeah,
ideal.
sort
Right?
of.
Yeah, sort of. Yeah,
It's like going through different.
Yeah. Yeah, that's a good way to look at it.
We'll call it a diuretic.
Yeah, that's a good one.
Diuretic. Oh my God, who thought of that? That's a great word. Put that in my little memory bank. Sodium bicarb is sometimes used as well. Again, not first line. Because it could cause other issues, as you know. But all of these things might be in the equation to get that potassium decreased quickly, knowing what's at risk. And then, of course, if we can't use medications to give it, we may have to consider giving dialysis to get that potassium out of there. You don't need to know how quickly it changes the potassium. You do need to know what are some options. Your patient has a potassium level that's high, that's what we give you in this scenario. What medications could be prescribed? So could you identify those, use all those on a list of some sort? Screen meds that have potassium in them. Sometimes we don't realize it, but some of these medications contain potassium. So you're going to have too high potassium, and I'm going to give you a medication that's going to decrease it even more? I don't think so. Aldactone, which we'll talk about more after a bit, spares potassium. So highly likely that if we give you a potassium level, you'll need to pick which diuretic you want to give to that patient, which we'll talk about coming up.
High potassium or low?
That retains potassium.
Yeah.
So you want that different. If your patient has potassium of 5.2, you don't want to give that diuretic to him. There are herbs, you don't have to memorize these, but interesting, there's herbs that cause you to have high potassium levels. You don't have to memorize those for the sake of a test, but if you're taking them or you have somebody that's taking them, they have too high potassium, those are probably not ideal choices for them. Herbs are interesting. Patients sometimes don't realize when you're taking herbs and how that's affecting things. There are drinks that increase your potassium levels. We'll go over some dietary potassium sources after a while. So I'm not spending a lot of time on them. You don't need to memorize all these juices that may increase your potassium level. We'll go through dietary stuff after lunch break. So basically teach your patient, tell me what medications you're on, tell me what herbs you take a look at your labels to see what's got high potassium content. Yes?
Can those same herbs be used to raise your potassium if you have low
Yeah.
potassium?
Yeah, great question. For sure. So that's a good point. So given the patient's potassium level, could you figure out what foods to recommend for him and what diuretic you're going to pick for him? So if you answer that question correctly, that tells me that you know what normal potassium levels are. You'll know if his is low or high, and you know what kind of foods would increase his potassium. Or if I give you a potassium of 5.3, well, you got to stay away from these foods. And orange juice won't be on your choices. I'm just telling you that you're 265, so bananas won't be probably on there either. Prevention of you having acute kidney injury, as we talked about earlier. Stay away from things that are going to cause them to have stressed out kidneys. We talked about those earlier. This is an important fact, kind of just as a patient education piece. If your patient is now 70 and he's only filtering half of what he did as a younger man, he may become digitoxic more likely, right? Because when he was taking digoxin at age 40, his kidneys were working fine. They're filtering at a normal rate. So it's keeping his dig levels correct. Now he's 70. He's still taking the same dose, but now he's starting to evidence signs of digitoxicity. And he says, well, why is that the case? I've been taking the same dose all along. And what is your answer to him as his nurse?
Your kidneys aren't filtering as fast as they
Mhm.
kidney.
Just by the age, the fact that you are now 70, your kidneys aren't filtering as well as they did when you were 40. It's just a fact of life.
So there's basically like a backup kind of.
Pardon me?
Would it basically be kind of like a
Yes.
gym, but not.
So his dig will just accumulate more because it's filtering less.
Do we need to know the signs of this?
No, you already knew that in cardiac.
Yeah.
Digitoxicity.
You mentioned what they are.
Who knows signs of digitoxicity? Oh, I know, it's been a long time ago, right? Who said it over here? I heard some. Digitoxicity. All right. If you don't remember those, I would put that back on your stuff to know, maybe not for 2 weeks from now, but for your final. But could you explain to your patient why they're having medication accumulation now as an older patient as opposed to a younger patient? Do you understand that concept? That's what's important to know.
Traffic is getting there.
Correct. Yep. Acute kidney injury, we were talking about recovery and so forth. Mortality is right there. So of course it depends on what was the initial event, how long were they in a decreased renal state, how well did they recover after we gave them medications, all of those other things, as you already know. Or their comorbidities. So lots of things can change that patient's ability to having normal kidneys or not. So we'll talk foods coming up. So don't worry about these at this moment. Questions about acute kidney injury. You absolutely will need to know the differences between pre-renal, intrinsic, and post. So this is what event your patient has going on. How would you categorize that? Know the differences between a risk patient, an injury patient, or a failure patient, given different assessment findings or history. Can you explain this medication accumulation piece? Could you identify meds that we would use for that high potassium level?
Wait, the medication accumulation, that's the
That's a toxicity conversation. You're now 70. Yes, we have to probably decrease your dose because you don't filter as well as you did as a younger person. And meds that we would use when we give you a high potassium level, you expect to see what medications to be prescribed. Could you identify those off the list if you needed to? We'll go over more dietary after this, we'll go through dialysis after this as well. Questions about acute kidney injury. Outcome depends on how long it lasted, how big it was, and how severe it was, all those things. Now we're not talking about acute kidney injury. Now we're talking about end stage. So the patient has had, their kidneys are done, shot. How will they appear? Very small and shriveled up. What was the only condition really where we said they're big and bulging and footballing? Polycystic kidney disease, correct. The rest of them, they don't get enough oxygen, they don't get enough blood flow, obviously they're just gonna start to shrivel up. Here's where we start to see significant signs and symptoms, significant lab changes. We've been talking about those all along. Look at that potassium level. So the kidney is not able to function at all, maintain lab values, retain, filter, all that kind of stuff. All body systems get affected. You don't have to memorize all these, because just think about all the times, all the stuff that can go wrong when kidneys aren't filtering the way it needs to. This one is a good slide to know, though. This one's a good slide to know. Your waste build up. Your normal kidneys, like you all, will filter those wastes to keep your BUN, your waste level, where it needs to be, between 10 to 20. This patient's filtering system is done for, shot, not working. His wastes are going to build up, build up, build up. He's going to have a crazy high BUN level, tell you his wastes are built up, and he could be evidencing signs of high retention of waste products, as evidenced by all of these. As you can see, there are some that are GI related. You're going to kind of categorize them. Bless you, unless that was a cough. And I still bless you, I guess. So as you can categorize those, some of them are GI related. Some of them are neuro related, as you can see. What is pruritus?
Itching.
Itching, severe itching. So your patient has kidney failure. He has a BUN of 45. You expect what indications of uremia? So you're saying it could be a sectality fly. That could be. Great. Great. I heard that sarcastic great.
Which ones do we really have to know?
Any of the above. But like I said, you can categorize some of them, or like the paresthesia, muscle cramps, and all them. You kind of maybe put them together. GI stuff, anorexia, nausea, vomiting. I don't know. I should probably come up with some kind of mnemonic to make those more understandable. I'll show you on that. They could develop the uremic frost, which is the crystals of waste products that have surfaced to the skin.
Yeah.
What do you suspect that patient's BUN is? Through the roof,
probably
yeah.
100.
They call that uremic frost.
You said it was like the waste that's not secreted.
Correct. Because your nitrogen waste, your waste products, all should be filtered by your kidneys, and your BUN then would be normal because you have a normal level of waste products. Now your kidneys don't work right. This patient's kidneys do not work right. They're not filtering correctly. Your waste products are just getting built up, and the resulting symptoms are these. And you look at that BUN number, and that's telling you how much waste product has built up. Blood, urea, nitrogen is what BUN stands for. These patients are very ill, as you can imagine. All of these assessment findings are consistent with what we've been talking about for this chronic renal failure patient. There's cartoons, there's mnemonics, there's lots of stuff but these are consistent throughout. Like I said, there's lots of, lower the GFR, worse things are. Now your patient is here. So we're gonna have to consider about dialysis treatments. Dialysis does what your kidneys are supposed to do, right? That's the whole purpose of dialysis. There are options for dialysis. One might be the typical one that you are used to, where they go in 3 days a week or whatever, and they have their blood taken off, run through a machine, and put back in. One could be continuous renal replacement therapy. Some of our clinical groups saw that on Monday. That's usually done in ICU, where it's a constant state of dialysis, where we're constantly moving your blood through the machine, washing it, and putting it back in. Or we could do peritoneal dialysis. We'll talk about all three of those. One size doesn't fit all. You know, it's like if somebody says, well, gosh, my neighbor they got to stay at home and they just could run their dialysis through their stomach. Why do I have to go into the clinic and get mine done? Well, yours is a different scenario than theirs were. So one doesn't fit all, and we'll talk about the three of those. Hemodialysis is kind of the traditional one that you're used to, where we take the blood out through a device, run it through the machine, get it all cleaned up, and put it back in. We want to remove the extra stuff that's supposed to have been filtered out that did not, the waste. We want to remove excess fluid as well. Because you know they're going to retain fluid because their strainer's not working correctly. There are 3 different devices we can do dialysis, hemodialysis through. We'll talk about the differences between those. It'll be important for you to know the differences between these 3. It'll be important for you to know the differences between these 3. One is through the central venous catheter. Obviously temporary. Because you can't go home and have a central venous catheter sticking out of your neck for a long period of time, right? It's rapid, we could use it quickly. That's what my sister had for a couple of days, because we can use it right away as soon as we put it in. They're gonna set it up so one port allows the blood to go out through the machine, another port allows the blood to go in, and oftentimes they'll have a third port that you can use as a nurse for IVs and stuff like that. So that's one. We can use it immediately. It doesn't stay for a long term, and it's effective for hemodialysis for that short-term use. Second one is a fistula. That's where we take the patient's own vessels, we manipulate them. So we fix one up to serve as the vessel that allows the blood to go out, and the other vessel we fixed up for the blood to go back in. That's called a fistula. It takes a bit to mature. That's the downside. Yes, I can put your fistula in today. There's less chance of rejection because it's your own vessels that we've manipulated, but it's going to be a couple months till we can actually start using it. So perhaps we have to do a combination, right? So if you need immediate dialysis, we might have to put this in short term, wait for your fistula to mature till we can use that. Or hopefully there's been conversation that your renal function is decreasing. We're going to talk about dialysis in your near future. If we put a fistula in today, hopefully we can get you to your dialysis in a couple of months. So advantage is its own vessels, less complications. Disadvantage, it takes a bit to mature. Kind of looks like this. Yes, you can definitely see it in the arm or where it's been placed. You as the nurse don't mess with it. That's their lifeline. Don't put IVs and fluids and stuff into it unless you're the dialysis nurse. Don't take a blood pressure, correct. Don't do venipunctures. Don't mess with it because it's their lifeline. This is the third type. This was called fistula. That means your own vessels. This is a synthetic. It's called a AV graft. Works the same, except it's man-made. It's synthetic. It's not their own vessels. It's one that they produced in a factory somewhere, and they put that in. Advantage, less time to mature. Disadvantage is we have all those issues with rejection, infection, all that stuff, because it's not their own vessels. It's something that got produced in a factory and we put it in the patient. So your patient's getting ready to go dialysis, and they're like, okay, I kind of got to explain to me, tell me the difference between a graft and a fistula. Could you do that as his nurse? If you can't, probably need to figure out how to do